This is a patient who had cataract surgery done somewhere else 2 weeks before coming to us, and she came to us with the IOL fallen on the retina. Half of it was touching the posterior pole, the retina, and half of the IOL was still floating in the posterior vitreous. We decided to perform partial vitrectomy to explant this multifocal IOL and to implant a new IOL sutured at sclera, because there was no posterior support, capsule support at all. We are using constellation machine and 3D Ingenuity visualization system, and for better visualization of the vitreous, we used fluorescein. So we perform a fluorovitrectomy on 25 gauge, 3 ports, using the external optic fiber for the visualization. First, we perform vitrectomy around the IOL in order to release it completely from the vitreous around it, because we didn't want to pull it when extracted it, and we left it falling on the retina. Now we continue the core vitrectomy, then the mid-peripheral vitrectomy, followed by the peripheral vitreous shaving. The fluorescein is very useful in visualization of the vitreous, and especially the peripheral vitreous. You can see how well it's visible, so we can shave it completely. We also perform anterior hyaloid vitrectomy and cutting off some posterior capsule remnants. And now with a crocodile forceps, we lift the IOL, bring it in the space behind the iris, retropupillary, and from there, with another crocodile forceps, we tried to bring it in front of the iris. We managed to do this for the left half of the IOL, and now we are trying to bring the right half of the IOL anteriorly in the anterior chamber, lying on the iris. Now the multifocal IOL, which was fallen on the retina, is now completely lying on the iris. Throughout the surgery, we protect the cornea with viscoat and metal cellulose, and now we are coming back to the posterior pole, trying to check if the PVD is complete, and if it's not, to complete it. The PVD was completely done, and now we are dealing with the IOL in the anterior chamber. We switch from the three-dimensional Ingenuity system to the surgical microscope, and under plenty of viscoat and the metal cellulose, we want to extract the IOL. We cut it, half of it, and then by rotation we withdraw it through a 3.2 millimeter limbal incision. Since there was no posterior capsule support at all, we are preparing for suturing an IOL, and our preferred method is suturing an Akreos IOL at sclera using Goretex sutures. This is a technique that I showed several times in several cases. We put 2 Goretex sutures through the eyelets of the IOL. After we marked the places for the 4 sclerotomies, 2 in the right side, 2 in the left side, done 4 millimeters apart and 2 millimeters away from the limbals, with the help of crocodile forceps via these sclerotomies, and with a handshake technique, we exteriorized the both ends of each of the 2 Goretex sutures. And now we folded the IOL, the Akreos IOL with a forceps and implanted, folded, through this 3.2 millimeter limbal incision. Now the IOL is in the eye, is almost completely behind the iris. Now it's completely behind the iris. We push the last haptic with a spatula, and now we pull, and we try to pull as even and equally as possible of the both Goretex sutures in order to obtain good centration of the IOL. We check this centration because the pupil became smaller and smaller. We check the centration of the IOL by pushing in periphery the iris, and only after we see that it is well centered, we finalize the suturing of the Goretex suture. Now we close the limbal incision with the 10-0 nylon sutures, and after we have a good intraocular pressure, we tried to bury the Goretex knot, which is quite big, so the maneuver for burying it is not very easy, but we use two movements of rotation and at the same time of pushing the knot through the sclerotomy. Now both knots, Goretex knots, are buried, the conjunctiva is closed, and this is how the eye looked the first post-op day. This is the patient's UBM in the first post-op day with a very well-positioned IOL. Thank you.